Hello everybody, welcome to our channel Medi-Concept. In this video, we will be dealing with the remaining part of our topic, abnormalities of adrenocortical secretion. Basically, in this video, we will discuss about two important diseases associated with the dysfunction of adrenocortical secretion, namely Addison's disease and the Cushing syndrome. Now, the first important thing you have to remember why this disease occurs. Now, just by looking at the name of the disease, you can simply remember. Like for the Addison's disease, it is the AD. First, it is AD. AD means the hormonal levels are low and you have to add the hormones from outside. Okay, like that in the Cushing syndrome, see the name, it is Cushing. So you can simply remember that everything it is high and there will be cushion of fat developed over the body of the patient. So just by simply looking at the name of this disease, you can remember why these things occurs. Now coming to the overall picture of the patient of Addison's disease and the Cushing syndrome. Like in the Addison disease, generally the patient will look thin, lean, weak and dark, whereas in the Cushing's disease, the patient will look big, round and they will be hairy. Now both of these diseases, the clinical symptoms occurs due to the dysfunction of the different hormonal secretion which are secreted from the adrenal cortex, namely the mineralocorticoid, glucocorticoid and the sex steroid. Now the most of the clinical features they develop due to the abnormal secretion of the glucocorticoid or the cortisol, either excess secretion or depressed secretion. Now we will discuss the clinical presentation of both of the diseases side by side for the easy understanding and the remembering of the clinical feature of both of these diseases. Now first, coming to the features that develop due to abnormalities of mineralocorticoid secretion, namely the aldosterone. So in Addison's disease, the mineralocorticoid it will be lowered, whereas in the Cushing syndrome the mineralocorticoid secretion it will be higher. But you have to remember, in the Cushing's syndrome actually the mineralocorticoid levels are not increased that much, but the excess of the cortisol, they have some mineralocorticoid like activity. So the features due to mineralocorticoid excess, it basically develops due to the excess cortisol, not the aldosterone excess. Okay. Next, in the Addison's disease, if the aldosterone secretion it is decreased, what will happen? We all know that the aldosterone it is important for the sodium reabsorption and the fluid reabsorption from the kidney, and both of these factors they maintain the blood pressure. Aldosterone it is also important for the excretion of potassium in urine. So if the aldosterone it is decreased in Addison's disease, what will happen? Sodium will be less reabsorbed, so the blood sodium level it will be decreased, leading to the hyponatremia. Also the fluid it will be less reabsorbed, so the fluid in our body it will be decreased, and both of these factors they lead to the decreased in blood pressure. Also decreased aldosterone lead to decreased in potassium excretion, so it will lead to potassium excess in blood, that is hyperkalemia. So if you perform ECG in this patient, that will be reflected as tall peaked T wave, which is the feature of the hyperkalemia. Now opposite of these features it will be developed in the Cushing syndrome. Like excess of mineralocorticoid, it leads to increase in the sodium ion reabsorption, that will be reflected in the increased sodium level in the blood. That means hypernatremia will develop. Also increased fluid it will be reabsorbed. So both of these features they lead to or they tend to increase the blood pressure. Also excess of cortisol, they tend to excrete more amount of potassium in urine, so the blood potassium level it will be lowered. That means there will be hypokalemia. Next is the clinical features developed due to the abnormality of glucocorticoid secretion. In Addison's disease, the glucocorticoid or the
cortisol, they will be lowered, whereas the cortisol level in the Cushing syndrome, it will be increased. Now, what are the clinical features that develop due to this abnormality? Now, cortisol, we all know, have profound effect over the metabolism. Like the cortisol, it increases the blood glucose level. So, in Cushing syndrome, prominently there will be increased in the blood sugar. So, blood sugar level or the blood glucose level, it will be increased. Next, the cortisol also have some effect over the fat metabolism and the protein metabolism. Over the fat metabolism, it causes redistribution of fat from the peripheral parts and deposit it over the upper part of the trunk, body, over the face and over the neck region. And that deposition of fat leads to development of buffalo-like hump. So, buffalo-like hump or deposition over the face along with the fluid and electrolyte reabsorption or retention that leads to puffy and round face, which is also called moon faces. Now, over the protein metabolism, it has catabolic effect. So, all the protein, it will be reduced and it will be broken down in the body, which will be manifested as the myopathy. So, proximal myopathy, where the muscle fibers or muscle proteins are broken down, it is the feature of Cushing syndrome. So, the muscle weakness will develop. Subcutaneous collagen tissue, it will be also decreased. So, it will tear easily and develop the purple stria. The stria it will develop. Stria will develop due to the tearing of the subcutaneous collagen tissue when it is overstretched, particularly like in the lower abdomen. Next important thing, that cortisol, it has some immunosuppressive effect. So, excess of cortisol, it will lead to the poor wound healing and recurrent infection. Also, the cortisol, excess cortisol, it will increase the osteoclastic activity of the bone. So, more bone resorption will occur, lead to osteoporosis. There is increased chance of fracture bone. Okay, so bone mass, it will be decreased. Excess cortisol, it also increases the acid secretion from the parietal cell of the stomach. So, hyperacidity occurs also in the Cushing syndrome. So, these are the features due to the excess glucocorticoid in Cushing syndrome. Decreased cortisol in Addison's disease leads to decrease in the blood glucose level and patient will lose weight. There will be easy fatigability or weakness. Also, the patient may complain of nausea, vomiting, abdominal cramp, and also the patient will be more susceptible to stress, because we all know that to cope up with the stress we need excess cortisol. Another important thing that occurs due to decreased cortisol in Addison's disease, that is development of excess pigmentation. So, hyperpigmentation occurs due to the decreased cortisol. Why it occurs? Because when the cortisol level is decreased, so the feedback inhibition of the ACTH secretion from anterior pituitary will be gone, will not be there. So, it will cause excess of ACTH secretion, and we all know that ACTH, it is synthesized from a common precursor of POMC, that is pre-opiomelanocortin, which is broken down into the melanocyte stimulating hormone MSH and the ACTH. So, whenever the ACTH is increased, the melanocyte stimulating hormone is also increased. So, that causes the hyperpigmentation. So, along with the ACTH, MSH activity is also increased. Also, the ACTH is broken down into the alpha MSH. That is also responsible for the hyperpigmentation. So, hyperpigmentation in Addison's disease develop due to the increased activity of the MSH.
Now, coming to the features that develop due to the abnormality of sex steroid or adrenal sex steroid secretion. So, in Addison's disease, the adrenal sex steroid, it will be decreased, whereas in Cushing syndrome, it will be increased. The features that develop due to decreased sex steroid in Addison's disease is decreased in libido in both of the sexes, and also decreased in the hair growth, because these adrenal sex steroid, they are important for the development and the growth of hairs. Also there will be menstrual abnormalities in females. In female particularly, there will be decreased menstruation, decreased or absent menstruation, that is amenorrhea. Excess of adrenal sex steroid in the Cushing syndrome leads to development of few clinical features, like there will be increase or excess hair growth, and there will be also menstrual abnormalities in females like excess menstruation. Okay, and also there may be also development of the acne. So these are the features of Cushing syndrome and the Addison's disease. Next important thing you have to remember, that how can you diagnose these diseases. Now from the Addison's disease, just look at the clinical features, like obviously the cortisol level will, so if you measure the blood serum cortisol or the urinary cortisol, it will be lowered, and if you measure the ACTH, it is actually higher. So increased ACTH and low cortisol is the classical finding of the Addison's disease. Next, the sodium level in blood, it will be low, potassium it will be high, and also the blood glucose level it will be lowered. So these are the features of the Addison's disease. Also we can perform another test which is known as the ACTH stimulation test. In that test, we can give the patient exogenous ACTH. So in normal person, that exogenous excess ACTH, it will increase the cortisol secretion, but in Addison's disease it will fail to do so. Now coming to the diagnostic features of the Cushing syndrome, along with the clinical feature, if we can say that the sodium ion is increased, potassium decreased, blood pressure increased, blood sugar it is increased, and along with that, if eosinophil count is lowered, we can definitely say that it is due to the Cushing syndrome. Now what is the actual cause of the Cushing syndrome? It is due to the Cushing's disease or some other pathophysiology. We can determine that by dexamethasone suppression test. Next, it is the treatment part. So treatment part, it is easy for the Addison's disease, as all the adrenocortical steroid hormone increased, so you have to supply the hormones from the outside, like you have to replenish the glucocorticoid or cortisol by giving the prednisolone. It is the synthetic cortisol or the synthetic steroid, you have to give it from the outside. Or to replenish the mineralocorticoid deficiency, you can give the fludrocortisone, right? And you have to advise the patient that never miss the dose, and advise the patient also to increase the dose in any stressful condition, because in such situation the excess amount of cortisol is needed for the body to cope up with the stressful situation. Coming to the treatment of the Cushing syndrome. Now depending upon the pathophysiology or the cause of the Cushing syndrome, you can surgically remove the tumor, like the pituitary adenoma or the adrenal adenoma, like that. If you can't excise that tumor surgically, you can do medical adrenalectomy, in which we can give high dose of ketoconazole or metyrapone. These agents decrease or inhibit the adrenal steroid hormone synthesis. So after medically adrenalectomy or by surgically removing the tumor, we have to supply the hormones from outside. So the surgical or medical adrenalectomy should be followed by the hormone replacement.